So here we are on the second of 3 of the video series, Avoiding Healthcare Dilemmas. This is the do everything dilemma. Again, I'm going to repeat, since these might stand-alone videos, this is not medical advice. I'm a healthcare provider, but I'm not your healthcare provider. So this is intended to inform you for your own reflection and discussion and documenting your wishes with your own personal healthcare provider. And since I practice in Michigan, if you're in another state, even more important to clarify your wishes with your provider or any type of legal or financial situations. All right, so Beverly's dilemma is she's 98 and she has Alzheimer's dementia. She completed a durable power of attorney for healthcare 15 years ago and named her son James. So wonderful that she planned ahead. What spurred her on to make those decisions is when her husband died of a heart attack 5 years ago. She said, I want you to do everything. She saw a scenario where there was a sudden medical event and it prompted their decision making. And she said, you know, if this happens to me, I want you to do everything. So that was the last discussion that she had with her son, James. Okay, sure. Okay. So Beverly is now in the hospital with pneumonia and weight loss. Thank you. I need so much help. Thank you for your help. So she is speaking a few words a day, and she needs help with all bathing and toileting activities. And we're going to look at what that means as far as where she is with the illness progression of dementia and how that can inform decision making when you kind of know is someone in early, mid, or late stages of this illness. So the dilemma here, the upside is that she does have a power of attorney of healthcare, and it's given to her son, James, and they've had a discussion about her wishes. So that part is wonderful. The dilemma comes in because heart disease and Alzheimer's dementia are very, very different illnesses. And what we call disease progression, or the other word we'll talk about is trajectory, it's not apples to apples. Okay, so Beverly likely did not have a real detailed understanding of what doing everything could mean for her with her dementia and the situation she might find herself in. So without really exploring the options for her, doing everything could actually bring on some unintended burdens and consequences. So everybody always has full choice, and any decision can always be changed. But if you don't make a choice, you receive the most intense level of care. Okay. So this is the illness trajectory concept. I have the resources if you're interested in the article. I have a resource site, so this is all stuff that's available to the public. I combined it in a graphic that helps people quite often think about where are they in their illness as far as planning goes. So with cancer, the general trend is that you're going along mostly fine, mostly mobile, verbal, able to make your own decisions with or without treatment. But then there tends to come a tipping point where people will say quite often, wow, that came on fast. Or we thought things were going okay and that came out of nowhere. So it's very common with cancer to have a fairly rapid decline over weeks to months. When someone is in their final part of the illness, it generally lasts from weeks to months. For organ and system failure, this would be things like heart failure, COPD, liver failure, end-stage kidney disease. Usually what happens, this blue line here, use this little hospital. I was going to try and get fancy. The blue line here goes along. So this is your functional level going across the side. And these little dips represent going into the hospital. So you'll notice with each little dip, you come out, but you're not quite exactly. Thank you. Okay. Now we're all awake. Thank you so much. So we're not really coming out of the hospital at the same level we went in. That's why you have therapy afterwards and regain your strength. So that's very common with illness projection. And the other thing you'll notice about this blue line is that the little dips are happening more and more often. So if we look at illness trajectory, most times it's months to years that someone starts having that accelerating pattern of going into the hospital or going to the ER and coming home or going into the hospital for stays for the flare-up of the heart failure or the flare-up of COPD. Okay. And that usually happens over months to years. So progressive neurological conditions are like the marathon of illness. These are things like dementia, Parkinson's disease, ALS, Lou Gehrig's disease, where quite often these things may have been brewing for a long time. When you look back, you can kind of say, oh, I see this maybe started 10 years ago, especially with like the case study we're talking about here with Alzheimer's dementia. That can be up to a decade of decline. It's very slow over time. And that's what in particular makes it tricky in the scenario we're talking about is her wishes 15 years ago and the do everything request 5 years ago really might have not have known what she would be facing and how long that decline would be. Oh, my clicker's stuck. I think I do. I don't know. So picky. Is there just a next slide button that you can do? I'll talk off my notes. So did anyone print out a set and bring it from the email? It's all right. That's all right. There we go. Okay, thank you. But you get a star for printing out and being prepared. Thank you. So if you overlay on top of these lines for illness trajectory, this is how TV and movies can alter our concept. One of the things in palliative medicine that we always talk about is what is your expectation or what are you hoping for in an event of an emergency? And a lot of times this bright pink line is what you see on movies and television is you're going along fully functional, you have a singular event, lightning strikes, you fall in. I think there's a movie out right now where someone falls on the ice and has a miracle. And I have seen things happen that are miraculous. Nothing that we do in medicine is going to be strong enough to stop a miracle if that's what's in the cards. But people's perception is that they'll have this event and they'll say, yes, I want to be resuscitated. Like we snap our fingers and you go right trucking on just like you were before with no changes. And so that's really not reality, especially in light of the illness trajectory model. So I'm a big fan of being really precise with language. And when you're asking people to describe their wishes, listening to exactly what they're saying, because if we say, the standard language is do not resuscitate. The better wording is do not attempt resuscitation. And the image here is of a light switch, because if you say, I've actually been in the ICU and a physician said to a patient, and if your heart stops, should we resuscitate you? That's a very well-meaning question. I, applaud the desire to talk about that. But if you listen to the language, it assumes a lot. It assumes that there's like a switch to be flipped and that we have the power to just do that because you say so. And that's not always the case. So more precise language is do not attempt resuscitation. And some people are at peace with this decision. And when I ask, one of the things I always try to start with in palliative is, what is your understanding of the situation and what are your general wishes? It doesn't do me any good if someone knows their wishes and says, it's my time, I'm ready, it's my time to go, I'm at peace with that. I don't need to spend 10 minutes talking about all the other alternatives. That's a waste of their time. I might provide some gentle education if they're a little bit mismatched with what I think they might want if they had all the information. But some people are really at peace with this. So the factors would be, what do you consider a quality of life? Sometimes people say, it really matters to me if I'm aware. Even if they're not able to communicate, if they're able to be aware and interact, then they would consider being on life support, either short-term or long-term, okay with them. And some people would never want to be on life support if they were unaware. These are things to think about. Others would look at quality versus quantity of time. Fixable versus permanent problems. I talk about this a lot in the ICU, is if it's something external happening to you, like an infection or fluid that's, trapped in your system that we can take back out of your system, those are more fixable problems. But when the organs themselves are starting to decline, We all, with being in Detroit, we all like to think that we can just put another part in, right? So I try to help people understand, this is what the medical team and all the specialists are saying about which problems are fixable and which problems are not. And we have discussions with all the specialists to help inform our meetings. And then substitute judgment. Sometimes if people are having a very hard time imagining what to do, we'll say, what would Betty say if she was able to sit right here and talk with us? Or the woman in the first scenario we talked about that was going to be back on the ventilator again. If we didn't know what her wishes were, based on what we know about her so far, what do you think she would say to us if she could talk? That's another good approach. So back to our scenario with Beverly, it's at this point that they ask for a palliative care consultation. The hospitalist, so the doctor, it used to be your primary care doctor that you saw in the office would round early in the morning and then go see patients in the office, but more and more that doesn't happen just because of how things are structured. And you have someone called a hospitalist who specializes just in in-hospital care, who's like the quarterback of the healthcare team while you're in the hospital. So the hospitalist made a referral for Beverly for our palliative team to talk with her about her clinical trajectory, which is the whole dementia process and where is she on that path, what are her specific goals, code status, because being full code and being where she is on the trajectory is a bit of a mismatch unless she's fully informed. If she's fully informed and that's what she wants, we respect her choices. But he saw that if she knew all the ins and outs, or if her surrogate decision maker, her son, knew all the ins and outs, there might be other alternatives that better meet her goals. And then what would be her wishes regarding artificial nutrition and hydration? We're going to look at that too. So James is here and he's worried about, what do I do for my mom? I have this information from her to do everything, but now things are getting more complicated in ways we didn't anticipate. So the way that we do a needs assessment when we first meet with patients and their families or their substitute decision makers is, what is his understanding of her health and current status? Sometimes people come in very, very ill and families just not aware. Either they haven't been involved or they're not really going to doctor's appointments. I think that's a great suggestion that we had from an earlier speaker is go to those doctor's appointments and take notes. And they're really thinking, oh, things are fine. This is a temporary blip, but doesn't really see the bigger picture. What kind of conversations and documents about healthcare wishes have already happened, right? We need to know what's happened before so we can meet them where they are. And then what matters to the most for right now and what matters for the future. Those are things we want to get a good understanding of from James before we move forward. And we don't have, one of the things that I always talk with people about is that palliative is not hospice. We're independent and we don't have a stake in what decisions they make. Our role is to support and inform. We're basically Switzerland. So if someone says to me, what would you do for your mother if you were me? I'll tell them my honest opinion and why, but I don't have a stake in what decisions they choose. And I say that up front. So James talks a little bit about how she's been doing. He says she's been more forgetful over the past 8 years, but she's doing okay overall. Her last expression of do everything made him decision maker, but that's all they've talked about since 5 years ago. He does see that she's becoming more frail, but he doesn't really understand what that's caused by. And he's thinking maybe it's pneumonia. He does want to honor her wishes, but he also wants to avoid suffering. And that's the key of the dilemma here. So one of the tools I bring when I meet with families, usually with dementia, we're meeting with the family, is called the FAST scale. Has anybody ever seen or heard of the FAST scale for dementia? Okay, yeah. So it's a helpful tool to help guide families as far as where is the person now. Alzheimer's dementia, there's several types of dementia, but Alzheimer's dementia specifically, we never know how long someone's going to have it for, but it tends to follow this set order of changes. So it's predictable in that way. Right now, looking at what we know about Beverly and how much she's really speaking fewer than 6 words, I did bring handouts also that have some of these key documents that are smaller type, so you can take a copy. So 7A is her ability to speak is limited to maybe 5 or 6 intelligible words a day, and otherwise she's not starting conversations. She may or may not be confused. She's already unable to handle toileting and is using voiding with a brief for bowel and bladder. But she's still able to walk with a walker and a lot of support. So that 7B is that puts her in the 7A, 7B level, which is in the final stage. This also helps us evaluate what is her hospice eligibility. We are not hospice, but one of the things our team always does is help look at, does this person probably meet hospice criteria according to the Medicare guidelines? So we can talk about when that's an option for families for planning, either for right now in the moment or for down the road. So everyone will move forward at a different speed. One of the things that tends to accelerate worsening of dementia is changing care settings. Someone can be really used to their home in the community for 20 years or longer, and then they go into the hospital or they go into an assisted living. Every time you change your care setting, you can kind of take a step down the staircase. That's very common. So James worries that, entering hospice because she is eligible here at 7A. She's also had some other conditions like pneumonia. She's had a urinary tract infection in the past, and she's had weight loss. These all paint the picture of how I could counsel him that she is actually in end-stage dementia, and hospice might be a helpful healthcare benefit. It's such a loaded word, and people hear the H word, and it becomes very emotional. I help people understand that it's not to shorten anybody's days. It's a healthcare benefit that might bring them more support at this time, and they can always sign in or sign out. They have control over that. So he just still feels that hospice might be giving up and not doing everything for her. And he does want the pneumonia treated, which is reasonable because there's really no burden to treating the pneumonia when she's in the hospital. But the thing that concerns us as a healthcare team is her code status, meaning if she were to have an emergency in the hospital, we would be required to go attempt CPR for her. Because unless you have someone saying otherwise, or you can speak for yourself otherwise, everybody comes into the hospital what we call full code. And that falls under that kind of do everything umbrella. And so in light of what we talked about with James as far as her eligibility for hospice and the fact that she actually is in end-stage dementia, it's really important to revisit that code status and do everything wish. So I use something called a GoFar calculator. I forget which university put it out, but you can find it online. It's called gofarcalc.com. And you put in about 8 or 10 different factors, things like age, was the person in a skilled nursing facility, so things about their healthcare issues, and they will give you a number. This is wonderful. We work with so many engineering types that want black and white numbers. And so when I work with an engineer, and I've been married to an engineer for a long time, concrete information is really the only way forward. And I respect that because these are really big decisions. So this tool is wonderful because it can give you some concrete odds of chance of meaningful recovery. So this site describes what they mean by meaningful recovery, and it's being able to interact and get around. So if you've lost mobility or if you're no longer interactive, that would be considered a poor outcome. A good outcome, according to this site, is interactive and mobile. Okay, even if that means just bed to chair or wheelchair, it doesn't mean you're walking exactly like you came in. So for her, she has a 1.9% chance of meaningful recovery and has a very, very high risk of either not surviving the attempt at resuscitation or persistent vegetative state, where she might be attached to machines long-term but not be mentally intact or interactive. So we talk about the 4 different elements of CPR and code status. How many of you have talked through this with a family member before when they were in the hospital, talking about code status? No? Okay. All right. So this is good preparation. And this is where I know the talk gets intense, but it's important to think about for an individual person's risk. So chest compressions is where you press the sternum to stimulate a heartbeat. Usually when it's done effectively, it will break ribs. That's survivable. But in someone's situation like, the patient we're talking about here, that might not be appropriate or what James would think she would want. Defibrillation is the shock to bring the electrical rhythm back, the pulse back. Intubation and ventilation is putting a tube down. The first tube is temporary, and then it's attached to a breathing machine. And some people need that short term, and some people need that long term. We'll talk about that a little bit more on the next slide. And the vasopressors is IV medicines that go in for blood pressure and pulse support. That's really not much of a burden. That's not a painful intervention. So this is not an all or nothing option. So this is why I'm hoping that talking about this today with you help you see that it's not just do everything or do nothing. This is where your knowledge of the person that you're making decisions for, or if you're specifying what your wishes might be in the future, it really is helpful to know that this is more of a buffet style decision than an all or nothing decision. And our job as healthcare professionals is to help you decide what would this look like for me personally and what are the risks of each of these. So because chest compressions would break her ribs, he chose no for that part. Defibrillation and shock is not pleasant, but it's short-lived and it could restart a pulse. He felt that was appropriate. It would be very unlikely that she would be able to wean off a ventilator because of her frailty and her advanced dementia. So he decided that he did not want her to even have a temporary breathing tube. And the IV medicines aren't really painful and they might help regain a pulse. So he chose 2 of those 4 items as a yes, and the rest he felt were not appropriate. So her code status was changed to be no chest compressions and no intubation, but everything else that's medically appropriate. And the other thing I want to say is this is only in case of emergency. All other care that's appropriate, treating the pneumonia, all the regular health care that would happen in the hospital still continues. These discussions are only about what would happen if there was no pulse and no heartbeat. What would you want done? That's a common question people ask. It's like, does this change my care now if I choose otherwise? So James does feel confident that this option honors her wishes and also reduces the risk of suffering that she could not really anticipate, both in the short term and in the long term. So she still receives full treatment for her pneumonia in the hospital. And this is a graphic that I made because we so often hear do everything, and we try to help people reframe it into let's talk about the specifics and maybe move towards doing everything that is helpful. Okay. So the other thing that we provide quite often in palliative care is what we call anticipatory guidance. If you were going to climb Mount Everest, you wouldn't just charge up the hill by yourself. You could, but most people hire a guide. So for people that we're referred, then we serve as that guide. So we're there to tell them what might be around the corner. So with dementia, we know that we always will have problems with eating. They lose their swallow and cough and gag reflex. It starts out as a memory loss disease, but it becomes eventually a whole body function disease. Food and fluids can go into the lungs, even silently. They may or may not cough, and that can cause a pneumonia. They can do a swallow study where they look with a video, or they can just do it at the bedside and see where's the food going. And quite often people are put on a held diet or a modified diet or NPO, which means nothing by mouth. So then the next dilemma becomes, now what do you do about feeding? And this is very emotional. How much time do I have left? Okay. So I'm going to go through this in kind of a faster way than I normally would, but you guys have some really good resources. There's a handout called Choosing Wisely that's available. You can just Google Choosing Wisely and feeding tubes and it will get you there. It's put out by, I want to say, the American Academy of Family Medicine and some other partners. Feeding tubes, John shared his short story with his mother, and he told me that he kind of felt push-pull, like they made the choice in the short term, but then someone said, why did you do that? The other part of the story that I got to hear that I don't remember if he shared is that she had throat cancer. That makes a big difference. So sometimes they're appropriate if you have a temporary reason not to be chewing and swallowing normally, but in advanced dementia, we know that it's a marker of very end-stage disease, and adding that artificial fluid and hydration can actually increase the burden. So we naturally want to provide nutrition. It's one of the most important ways that we care as a family. You can do careful hand feeding. Feeding tubes are more convenient for the staff, but this is another thing where if you know your rights and this is what you want, you can advocate for what you think is best for your loved one. We also encourage people to think, why are they not eating and drinking? Often it's because they're in the final stages of dementia. So some of the negatives to think about a feeding tube are that it can cause bleeding, infection, blockage, or leaking. Fluid overload can make breathing tougher, especially for people who have kidney disease or heart failure. They actually do increase the rate of people getting pneumonia because the liquid nutrition goes up into the lungs. They're associated with a higher incidence of pressure ulcers. I think it's because they're in end-stage dementia and they're not able to use the nutrition. I don't think they actively cause a pressure ulcer, but the body's just not able to use those protein and those construction materials to rebuild the tissue. And often people need to have restraints to stop from pulling them out, which can be really distressing. When you're looking at would I want a feeding tube, it's generally because you would want to extend someone's life. On average, they can extend people's life by days to weeks. There are situations where people will have them very, very long term. And then that's where looking at something like that FAST scale helps you see what stage are they in today and what kind of quality of life could we maybe expect in the future. And that can guide your decision making. So comfort care in advanced dementia focuses on pleasure foods and connection. Sometimes people just want to taste and swallow a little bit and have that interaction of mealtime. People are usually not eating because it's part of the dying process. We coach families to let the body be the guide. If the patient's not experiencing hunger or thirst, it's because their body can't handle it and they're shutting down. So quite often we want to feed because we're worried. But if they're asking for food and fluids, give them carefully. If they're not, that's because that's where they are as far as being in that process. And this is where being on hospice, if you're on traditional medical care, just not feeding somebody is not okay because you're not in a comfort care situation. We coach people that if these are your goals, these goals are best met in hospice because we can help guide through that process so that there is not starvation, there is not someone dying of thirst. These are all the things that people imagine that are the worst case scenario. It can be managed in a way that's dignified, helps the person enjoy and interact as much as they can, but doesn't prolong their suffering. So James' plan forward for his mother is, I have to check in and say, how are you doing with all this information? It's kind of a lot to hear and think about. And, he is tearful for a minute, and that's kind of appropriate. Part of my job is that I make people cry several times a day, and it's hard, but I know that sometimes if people are just thinking so much about the tasks and the checklists, and what are we going to do, check, 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 they're not really understanding. So as much as it's hard to see them cry, it's part of my job to help them get to that point of understanding. No, I'm going to cry. But it's important because if you don't have the information, you might up in a place that you would never imagine you wanted. And so that's our role. So the plan for this scenario is that Beverly will finish the 2 remaining days of antibiotics. James meets with hospice at the hospital to learn more about that. And the plan is that she really, he feels comfortable with her assisted living and that she will go home and start hospice back where she had been living in the community. So most hospice is provided wherever people call home. Sometimes people think it's a building that you go to, like I'm going to go to hospice. Most of it happens wherever the patient lives, and talks about the services that are available. Beverly can still have small amounts of food and fluid for pleasure, and we follow her cues when to stop. Okay. So the things that you can do for your next steps for this second video of the 3 is talk to your primary care provider about yours or your loved ones, what we call illness trajectory. Where are they in the span of their illness? Getpalliativecare.org is a really good website that you can actually look for more information about this by disease type. Talk with your power of attorney and family about your wishes and what you consider quality of life. That's been the overarching theme of today. And then complete your advance directive so that it's documented. And thank you.